Hello, everybody, and welcome to the next module in the course. This module is going to deal with the therapies and treatments for autism spectrum disorder. Please keep in mind kind of two things. First one is that the textbook in this part of the class doesn't really cover in a lot of detail some of these different treatments, therapies, and different components of those treatments and therapies in terms of how they're delivered and to whom they're delivered to. So because of that, the PowerPoint and the lecture are going to go into a lot greater detail. Now, that being said, this isn't really a deep dive into it. The way this course is set up is that there's a lot of different components that I have to talk about throughout the semester. So this isn't going to talk about each and every individual therapies, treatments, and research into those therapies and treatments that are going on now. It's just I'm time limited. I can't possibly go into all that detail. So what the focus is going to be is really on hitting kind of the key components, some of the most common aspects of the therapy and treatment of autism. In keeping with that, the kind of general overview of how I'm going to be presenting the information today is I'll start by talking about some of the practitioners that work within actually delivering these therapies and treatments. I'll also talk a little bit about the costs associated with autism treatment. I'll then transition into talking briefly about what evidence-based practices are, just what that term means, and then go into some of the more common childhood treatments. There are several different types of treatments across many different fields, different disciplines. So I'll kind of hit some of the keynotes there, some of the most commonly used evidence-based practices. After that, I'll go into a little bit of a discussion on some lifespan considerations, and then finally end with the last slide, just, if you will, a little bit of a soapbox moment, talking about some of the challenges, some of the barriers of therapies and treatments, both currently and also as we move into the future. So when we talk about the different people who actually deliver these therapies and these treatments, it gets quite a bit complex, and you can probably tell that by looking at the PowerPoint slide in front of you. So there are many different disciplines, many different fields, many different types of practitioners that really play a central role in delivering these treatments to those with autism spectrum disorder. Up first, of course, because this is the category I fall in, so I have to list it first. I include therapists. Now, this can be a wide range in and of itself, right? So it's a very large category. It can include people like licensed clinical social workers, licensed mental health counselors, and licensed marriage and family therapists. So that's those letters you see: LCSW, LMHC, LMFTs. Those are terms that are used in Florida. Sometimes they can be somewhat different, slightly different based on the state you're at, but all states have some version of those. These are all master's level trained individuals. Some of them also have doctorates, but in order to practice at that license level on the state, it's a master's level. They provide one-on-one individual kind of psychotherapies. They can also deliver group therapies, family therapies, things like that. This is the typical counseling you kind of think of. Also included in this would be psychologists. Psychologists can do all those things I just mentioned. They can also be involved in assessments, so actually making the diagnosis of autism spectrum disorder. Generally speaking, in most states, the people making those diagnoses are psychologists or psychiatrists. Technically, I believe in Florida, pediatricians can also make a diagnosis. In my experience, that's rather rare. In some states, I don't believe Florida is one of them. LCSWs, LMHCs, and LMFTs can also receive specialized training to make a diagnosis. That's kind of rare, though. It's worth noting also when I'm saying can make a diagnosis, LCSWs, LMHCs, LMFTs, they can diagnose really anything out of the DSM. Technically, they can diagnose autism spectrum disorder. The difference, though, is that when it comes to what insurance companies basically pay for, they kind of run the show in the United States when it comes to healthcare delivery. They really only will acknowledge it if psychologist, psychiatrist, pediatrician, really is the one who approves it. And depending on the state you're in, also there could be state laws that influence it, as in Florida. So that's the therapist column. We also have, I already kind of mentioned this, pediatricians, a lot of different medical specialists. So uh, in my experience, it's kind of rare a pediatrician, kind of the run-of-the-mill pediatrician that you may take your kids to get vaccinated, their well kid checkups, things like that, aren't usually actively involved in autism treatment diagnosis, other than the fact that oftentimes it can be a really good first line um, provider in kind of screening and recognizing symptoms to make the referrals. Typically, when we talk about medical specialties that work directly with assessments and providing treatments with individuals who have ASD, with children who have ASDs, we're usually talking about specialists, in fact, very specialized fields, things like pediatric neurologists, pediatric psychiatrists, and of course, this is notwithstanding if there's other medical issues that may come up. And if you remember back when we talked about some of the challenges in co-occurring slash comorbid conditions, a lot of different medical conditions can fall in that category. So of course, if a child has autism and some of those medical concerns, it may involve more medical specialists. Moving on, we have occupational therapists. So occupational therapists are often kind of misunderstood. I know in my experience of working within healthcare settings, when I mention occupational therapists, oftentimes people think I'm trying to tell them to get a job. Not the case, right? We hear occupation, we think jobs, but occupational therapists, I'll get into greater detail as we go into the lecture, really provide therapies, treatments, help in guiding people through kind of their daily routines. But I'll get into that a little bit more later. Likewise, speech language pathologists. Uh, they work with speech disorders, communication issues. So obviously, that's a very big part of ASD. It's worth noting, I talked a little bit about the educational academic background for the therapist. Obviously, pediatricians, medical specialists, they have to go to med school. Occupational therapists, I'm pretty sure, are still at the master's level, so that's usually a closed master's level program that you have to apply to and get into. Likewise, for speech language pathologists, I think last I checked, that program is kind of trying to push towards requiring students to get a doctorate in order to practice, but I don't think they're there yet, but don't quote me on that. The next up, we have behavior analysts. And this is really kind of a broad field in and of itself also. I don't have them all listed here. But generally speaking, when we're talking about behavior analysts, we're talking about applied behavior analysis, or ABA, a really big treatment that I'll be talking about later in the lecture today. Within that, these are the people who actually apply the principles of ABA and work with the children, usually children, who have autism spectrum disorder. Now, there's a variety of different practitioners within this field. At the initial level, as far as the ones who more or less have a lot of the one-on-one time with these kids and actually kind of implement a lot of the practices in ABA, we have registered behavior technicians, or RBTs. So these are the ones that actually kind of apply whatever the treatment plan is, work one-on-one with the kids, and implement the ABA practices. I believe this is still a certificate program. I think there was a push to make it more of an associate's level degree. One step, kind of more on the supervision aspect from a registered behavior technician, we have people who are bachelor's level trained, and oftentimes for those, you can hear them referred to as board certified assistant behavior analysts. I don't believe in my experience that that tends to be very common, but that would be a bachelor's level trained. And then sort of at the top of the supervision pyramid for ABA, we have what's known as a board certified behavior analyst, or a BCBA. So these folks have master's level training. You can either do that as its own program and get a master's degree in applied behavior analysis to become a BCBA. There are also different ways in which people who are, say, an LCSW or a psychologist or have training in some other type of related profession can do an abridged program and become also a BCBA. I've known a few people who have done that through LCSW and LMHC routes. Not super common, but it is possible. Usually, the board certified behavior analysts, the BCBAs, they play more of a role in organizing the treatment plans. They don't really have a lot of time, or a lot of their time is spent one-on-one working with the kids. It's really creating the treatment plans and then supervising and making sure that those treatment plans are being adhered to and to see if they need to be changed at all. So it tends to be more of a supervisory role. Beyond that, and again, this isn't necessarily an exhaustive list, we have school social workers, case managers, either with the schools themselves, or oftentimes you see where there's a variety of different state programs, insurance programs, and frequently there's a need for case managers to kind of get involved and take more of an active role in helping the clients and the client's family, those with ASD, kind of navigate all these different professions, all these different practitioners, all these different interventions that they may be dealing with. Again, not an exhaustive list. There's probably many, many, many people that I've left off, but I think that kind of tends to hit sort of the key parts of some of the people in the different professions that are involved in treating individuals with autism spectrum disorder. So this slide is kind of interesting, and I'm not going to go over each and every component, but oftentimes I have seen cited for many, many years now that autism spectrum disorder is actually one of the most costly disorders. And one of the reasons for that is we've gotten really good at recognizing it and being able to diagnose it early in life. So oftentimes we're having kids really in late toddlerhood and early childhood being diagnosed with this. And autism in and of itself doesn't limit a person's life expectancy. So theoretically, I think in the United States now, the average life expectancy is mid 70s, upper 70s. So you're talking about perhaps 70 some odd years, where a person's going to have this condition. Now, especially early on, when we're talking about in childhood, there is a critical period of early recognition and early interventions. And this is just some of the costs associated with it. So you kind of get an understanding of why it's considered to be such an expensive disorder. Right off the bat, we have things like the initial diagnostic assessment, which is often $1,000 to $5,000. And could be more if you're talking about also screening for things like learning disabilities, attention deficit hyperactivity disorder. Speech language pathologists can bill anywhere from $100 to $250 per hour. Usually it's about an hour session that they do. That can range from once or twice a week, generally for months or even years. Occupational therapy can be about $100 to $200 per hour, again, weekly, biweekly. Applied behavior analysis. This is kind of a wide range, but generally speaking, it's about 120 to 150 hourly. I have seen a wide variety here, and we'll talk about some of the different types of ABA. There are some programs that are way more intensive to where people are getting, it says here 10 hours per week. I've even seen some that are 20 or 30 hours per week, like really super intensive levels of ABA. So you can see where that cost would really rack up. And then on here, counseling therapy, about another $100, $250 per session. Usually that's once a week. Once a child becomes more stable, their family isn't really dealing with any issues and have kind of come to a happy place, that may be trailed off to where it's not weekly. But you can certainly see it really wouldn't take much here for these costs to just really start piling up and really get into some astronomical levels, especially when you're talking about after weeks, months, and years of getting this treatment at a minimum weekly. Now, of course, I'm giving you those stats. The average family isn't paying that out of pocket. Most insurance companies, if a person does have insurance, those insurance companies are paying for it. Every state in the United States has a requirement for autism spectrum disorder to be covered by insurance companies. if children don't have insurance through their parents, their caregivers, most states, do have at least some form of Medicaid set up for those children to be covered, and all of those cover autism spectrum disorder also. But the thing is, and this is kind of something for you to know, whether you have a, family member, friend that has autism, if you have a child that has autism, but there is a large number of children who are on state-funded versions of Medicaid, and because this is so costly, that is a cost being picked up by taxpayers, that's being picked up by the general population. So there is a real vested interest in keeping these costs down while still providing quality care. And that's something that's kind of influencing really where we're at with different types of treatments moving forward when we're talking about research, is really looking at the most efficient types of treatments. Another thing to keep in mind is that location really does matter, and that's in a variety of different contexts, right? First off, urban versus rural. Generally speaking, the more options you have, the more competition there is. Cost can sometimes go down. So that means urban areas sometimes can be a little bit more cost effective compared to rural areas where there may not be that much competition. Of course, then the flip side of that is you may not have access to all the resources if you're in a very rural area. Likewise, some cities are way more expensive than other cities, so that can influence it. The state that you live in, I mentioned that all states require their state mandates to cover autism spectrum disorder treatment. However, not every state is equal in how they do that and how well they do that, and how much they provide. Florida, generally speaking, ranks around 20th, so we're not the worst, we're not the best. It's kind of interesting though when you think about it. I encourage you all to kind of do this on your own, but look up some of the statistics here, and what you may think of a misconception of states that would be well funded in this area and states that wouldn't be well funded would probably be surprising to you, because it really is kind of random. You have states that are generally considered to be kind of more socially minded in their welfare system. So places like, California, Massachusetts, some of those are very well funded states. Some of them are not. New York, in particular, is not one of the ones that really is above board on providing a lot of treatment. Other states, oftentimes, we don't look at as being very progressive. So states like Arkansas actually do rate very high in providing the treatment for autism and what they cover. So it's just kind of interesting. Another thing that matters is also the provider credentials. I just talked a little bit about the BCBA versus RBT. If you're getting your therapy from a clinical psychologist who specializes in pediatric disorders, it's probably going to be a lot more expensive than going to a licensed clinical social worker. That doesn't necessarily always translate, though, also, just to clarify, into it being better. Just because you're going to somebody who has a doctorate and you're paying more for it doesn't necessarily mean it's better care. So just kind of keep that in mind. The severity really does drive the cost too. If you have a child who has more severe impairments with autism spectrum disorder, not only is that probably going to require more interventions from different practitioners, but also probably more frequent interventions, right? So maybe instead of once a week or once every other week, this could even be 2-3 times a week. So that could definitely make a big difference. Diagnostic costs may be covered at no cost through public school systems or Medicaid in some states. Private pay generally tends to be more at the higher end. Florida does do diagnostics assessments through the public school system. The caveat there is that we're trying to identify autism earlier and earlier. So what you kind of see now is that unless it's more of a higher functioning form of autism, we're generally trying to identify it before they even go to the school system. Services may also include educational support, specialized schooling, assistive technology, all sorts of different other things which can definitely rack up the cost. So I'm putting this out there not to be a all-encompassing list again, but just to give you an idea of why it's so expensive and some of the different aspects that kind of can really drive up the cost when we talk about autism treatment. Now moving on, I'm going to start talking about some of the specific treatments. And before I do, I just want to reiterate a term that many of you may be familiar with, hopefully you're familiar with, and that's evidence-based practices. So, evidence based practices, or EBPs, are defined by the American Psychological Association as being the integration of the best available research with clinical expertise in the context of patient characteristics, culture, and preferences. What does that mean? That means that we're only really applying interventions, treatments that have been studied, that have been researched, and not just once, right? We're not just doing one experiment and saying, well, it worked here, it must work all the time in all contexts, but that it is being checked and rechecked, that it has validity, that it has replicability over time, that it's a reliable intervention. Also, not just that it's a reliable intervention, but that it's one that is safe to use, right? So that's the gold standard. That's what we need. I just talked a lot about the cost. Insurance will oftentimes, not often, only, it will only pay for treatments and reimburse for treatments that are evidence-based. Um, Many interventions must be tested and scrutinized to determine the efficacy while also balancing the safety. So it's worth noting that to develop these, it is kind of a time consuming process. We're lucky in that a lot of the interventions that we talk about with ABA, they're not things like medication. There's really no medications as we are right now in 2025 when I'm recording this that are used specifically just to treat autism spectrum disorder. Now, when we talk about medications, those are longer processes to become evidence based, to be valid, and to be approved. Therapies, kind of the treatments we're talking about here, non medication treatments, aren't as critical because generally speaking, the possible consequences aren't as severe as if you give somebody a medication that could lead to them having cancer. But that being said, it is still a little bit time consuming. Now, here's the thing, right? Because there's so many people with autism and because there's so many people who care about them getting the treatment that they think they deserve, oftentimes what that means is that there's a lot of pressure to kind of rush this process. And there's a whole bunch of, I'll be kind here and say, false treatments that are frequently presented, oftentimes with the best of intentions, sometimes not with the best of intentions, but rather with the goal of just trying to get people to buy something so that somebody can make a whole heck of a lot of money off of them. I'm kind of encapsulating all this under that last bullet point. There are numerous pseudo treatments, so buyer beware. In this class, I've tried to really push for you all to be skeptical consumers of research, of information that's available online. And part of the way to do that is do your own research. Look for journal articles, look for credible sources that really look at whether or not the intervention you're talking about, the aspect of autism or whatever you're looking up is evidence based, that it's gone through scientific research to determine that it is effective. Because I can tell you right now, especially when it comes to autism, folks, there's a whole lot of misleading stuff out there, and there's a whole lot of people that honestly just want to take advantage of desperation, hope, ignorance to make money off of it. So definitely be careful. All the interventions I'm going to be talking about today in this lecture are evidence-based, and in fact, they've been researched for quite a while. Up first, we have probably what many people would consider to be one of the gold standard treatments for autism spectrum disorder, and also probably one of the most widely used interventions, and that's applied behavior analysis, or ABA for short. This is an evidence-based therapy that uses principles of behavior to systematically teach new skills and reduce challenging behaviors in individuals with autism. It really comes from operant conditioning. So this may be a little bit of a throwback to all of you, to general psych. If you remember, operant conditioning is a form of associative learning where you basically kind of change your behavior based on the outcome of that behavior. All right, so when it comes to applied behavior analysis, what we're really focusing on here is positive reinforcement. A kid's going to do something because there's a benefit of them doing it. If there's a benefit to a behavior, they're more likely to continue with that behavior. That's really kind of the core of ABA. Another key component of operant conditioning that comes into ABA is something called shaping. So what shaping means is that the more complex the behavior is that you want the person to do, in operant conditioning, they would say the organism, right? But we're talking about people here. So the more complex the behavior is, the more difficult it can be to teach that, to change your behavior. So what you have to do is kind of break it down in small little baby steps. So maybe with applied behavior analysis, if you're working on something like social skills, for a young child that has autism spectrum disorder, it may be really overwhelming for them to do something like walk up to a kid in their class and just start talking to them, right? That's a really complex behavior for them. So what you would do in applied behavior analysis is kind of break that down into small little steps you can do along the way. Maybe just start with role playing, with speaking to your therapist in ABA, or maybe it's just making eye contact or something like that. And once the child masters that skill, they can go on to a little bit more complex one. And each step of the way, they're working their way towards being able to have a conversation with a classmate, something like that. So hopefully that's a good example to kind of drive it home. Now, ABA is generally used from about early childhood through adolescence. I would say it's not really usually started at adolescence, usually started in early childhood, but it can continue on into adolescence. And indeed, the scope of it can kind of change as a child goes into adolescence also. There are some concerns on here. So one of the things I see more than anything, and I think this is more true of earlier forms of applied behavior analysis, is that sometimes it could be a little bit overwhelming to the child. I know I've certainly met adults who have autism spectrum disorder, young adults who kind of talk about going through ABA, and I definitely have heard a few that kind of said they did feel very overwhelmed. In some cases, they may not have necessarily felt like they were being heard. Certainly, early criticisms of ABA, and still some criticisms of ABA from the neurodivergent kind of advocacy community, is that ABA is really meant to just help those with autism mask their symptoms, to try to normalize who they are. And whether that's a fair criticism or not, I'm just telling you that is a lot of the things that are said about ABA. That being said, though, ABA has kind of still been one of the gold standards. There are two main kind of methods of ABA. What's known as DTT and NET, which I'll talk about in the next few slides. Some of the challenges here, some people kind of believe it may be a little bit too rigid. I would argue, though, that kind of rigidity in organization and structure is actually beneficial when you're talking about autism spectrum disorder, because oftentimes kids, even adults, kind of thrive on that rigidity and that structure. The other big challenge here is that there is kind of a need for specially trained individuals. So that kind of goes back to what I just talked about with the BCBAs and the registered behavioral technicians, all this other stuff. I can say that, especially those BCBAs, there is a bit of a shortage of them. Kind of is a decreasing shortage, but there is kind of a shortage still, especially in rural areas and certain other parts of the country. So that's definitely a potential challenge to delivering ABA. So as I mentioned, there's two types or two methods of ABA. The first is DTT, or what's called discrete trial training. So with this method, it tends to be a little bit more structured than the other method I'll be talking about in the next slide, and it's a little bit more direct. Oftentimes, the therapist is teaching one skill at a time through a repetitive sequence of trials. So this is where there's a very clear instruction. The student or the child is going to respond, and then a reinforcement is going to be given. With ABA in general, I talked about positive reinforcement. So remember, with operant conditioning, there's other things like negative reinforcement, positive punishment, negative punishment. Those aren't really used with ABA. It's only positive reinforcement or no reinforcement at all. So that's kind of important to know. And that positive reinforcement is only given when the target behavior is actually done by the child. Now, the environment for DTT, this is kind of really what distinguishes, in my opinion, DTT from the next method I'll talk about in the next slide. With DTT, it's usually done, it's actually delivered, like the actual therapy is done in a controlled environment. So oftentimes this is usually in a therapist's office. Back in the day, it was very sterile kind of lab settings. It's not really like that now, but the idea is still to have as distraction free of an environment as possible, because then the child is able to just focus entirely on the actual behavior that is trying to be modified. The goal of DTT is used to teach a foundational skill like matching, identifying letters, or following simple instructions. And it's usually done through just repetition, right? Just repeating it over and over and over again until the child does the behavior, engages in that skill, and does it consistently. One of the big limitations of DTT is that it can sometimes feel really artificial. I know one of the things I kind of hear from children is that this isn't fun, right? I mean, just think about it, a kid, where you're just repeating something and you're having them do it and you're just doing this over and over and over again in a distraction-free environment, so they can't even kind of have their mind wanders or play with anything else. They're just having to focus on that. So you can kind of see where that'd be a little bit difficult, especially if you're younger kiddos. One of the other limitations here is because it's done in a really controlled environment. It says here it's not automatically generalized to the real world. Think about it. If a kid's learning a skill, but they're doing it in a therapist's office with not a lot of distractions, they could master that skill. But they're only mastering that skill in that setting, not necessarily in the real world where there's always going to be distractions. So that's what I mean about generalizability. Moving on, the next method in ABA is what's known as natural environment teaching, or NET. So with this method, the child is kind of engaging within a natural environment in the interest to teach skills in a more relaxed, kind of flexible way. So, like I said, this is kind of the big thing that really distinguishes DTT from NET is really just the setting where it happens, right? With DTT, it's in a controlled setting, limited distractions, usually a therapist's office. With NET, it takes place in nature, right? At the kid's home, at a playground. Sometimes they're done in stores, schools, you name it, right? The idea here is not to have a distraction-free environment, but to have, a normal, natural environment to learn the skill where the kid's going to be using the skill. The goals are aimed at making a learning experience that is more relatable, to boost motivation and teach skills in the context they will be used, such as asking for a toy that the child is interested in. Limitation-wise, some skills may require the more structured approach of DTT initially, and it can be harder to ensure consistent repetition. We live in a world that's constantly changing, right? So that's kind of one of the flip sides, is that when you're learning these skills in a really changing situation, well, that can be quite different. You take a kid to the playground to learn social skills, and that happens to be a day where it's raining. Or it happens to be a day where maybe one of the kids on the playground is kind of bullying other kids. That's going to be a lot more difficult, right? So you can't really account for all that with NET because that's life. So something that can be really important. Also, because it's not in a distraction-free environment, that does mean that it could be more difficult to kind of keep a kid focused and kind of reined in on the actual skill being taught. The next part of ABA I wanted to talk about is something called task analysis. So task analysis is a technique. It's not like the methods I just talked about, right? Those are two big methods that are a little bit different from one another. Task analysis is a method. It's a technique that can be used in either DTT or NET. What it entails is using more complex, kind of a multi-step skill that is broken down into the sequence of smaller, more manageable steps. So when I talked about ABA, I mentioned that it's based on operant conditioning, and I mentioned the element of shaping, that more complex behaviors are kind of broken down into small little components. So in ABA, when we're breaking it down to those small little components, we're doing this task analysis. That's what they call it, task analysis. So the steps are taught individually until they're mastered. And then once they're mastered, the therapist, the technician puts them all together so that the child is able to engage in those more complex behaviors after they learn those little baby steps along the way. The goal here is to teach functional multi-step skills, things like getting dressed, brushing your teeth, preparing a snack, and to do that independently. And again, especially for children, really for any children, but especially children with ASD, these are things that can be a little bit problematic and difficult. And learning them can help teach a little bit of independence. It can help them feel a little bit more self-aware, self-secure, and confident. Now, one of the limitations with task analysis, just kind of keep in mind, right? This is not a standalone method. It is used within NET and within DTT, right? So it's not its own thing all to itself. And it is very solid. Just kind of an easy way to think of this. If you remember operant conditioning, task analysis is basically shaping in ABA. So one thing I did want to talk about here, just to kind of summarize everything with ABA, and again, this is not meant to be an exhaustive, detailed description of all components of ABA, but just kind of give you a broad overview of it. So the two methods I mentioned, the NET and the DTT, oftentimes are used in combination. So it's not like it's just, you pick one or the other based on therapist preference or based on the child. Oftentimes it's a little bit more nuanced and kind of complex. So oftentimes, a child may first learn kind of basic skills in more of like the DTT types of session, where it's a little bit easier for them to learn and to focus. And then as they start to master it, they could transfer that skill on into more of like an NET session. Right, so the example given here is they may start to learn colors or something like that in more of a structured environment with DTT, and then start to apply that in a real world setting. So for example, on here, if they're identifying their colors, maybe in a NET session, they're going to go and start painting or doing something like that. In keeping with that, then task analysis is used to create the teaching plan for complex skills, which are then taught using either DTT or NET. So hopefully that's not confusing to anybody. And again, ABA is way more complex than this. This is just kind of a Reader's Digest version of what it is generally. So I mentioned that applied behavior analysis is oftentimes viewed as being kind of the gold standard for treatment. It is by no means the only evidence-based practice, though. There are several others I'll go into as I go through the next few slides. The next one I want to talk about is what's oftentimes referred to as NDBI, or naturalistic developmental behavioral interventions. So these are a type of intervention that combines developmental and behavioral aspects to teach skills in natural settings like the home, the school. These interventions use child-led activities. They share control between the child and the therapist and use natural rewards to teach communication, social skills, and other developmental goals. Oftentimes, the way I like to kind of describe the difference here between ABA and NDBI is that what I just talked about with ABA, remember, it's kind of very structured, right? A therapist is identifying what the target behavior is. They kind of use that task analysis to break it down into small little components, and it's very structured and kind of organized. And it's really the therapist that's kind of running the show on that. They're interacting with the kid, but it's really them that are kind of structuring that. With NDBI, that structure isn't really there so much. So what's happening is you're just kind of letting the kid do what the kid normally wants to do. If they like playing with Legos, you're watching them and letting them play with Legos, and then you try to kind of intervene and put like deeper lessons or skill learning within the context of what that child wants to do. That doesn't mean, just let them do whatever they want without any question. And sometimes there's a little bit of what I kind of like to call like gentle nudging that kind of happens of directing kids in certain directions, but it's certainly much less structured than ABA is. It's generally speaking best for preschool and early school aged children. And one of the big advantages here is because it is more play based, and the kid kind of has a little bit more flexibility in deciding what they want to do. Oftentimes kids enjoy it more, right? Because it doesn't feel like work, it feels more like play. And because of that, it tends to be a little bit more flexible too. And you think about how kids normally behave, they're not really structured and organized. They do kind of have this level of flexibility they like change. They like to jump from one thing to another. Um, One of the problems though is actually that in and of itself, right? So one of the barriers here is that you have to be really actively engaged with your kid a lot in order to pick up on what they're doing and try to connect it into some larger skill training or learning experience or something like that based on what the child's interest is at that time. So you can kind of probably get a little bit of appreciation of how difficult that would have to be and just how much time and effort you would have to devote to this. So just like ABA has two different methods, NDBI actually has two different methods also. In my way of looking at it, I don't really think they're as distinctive as the two different methods in ABA, but there are some distinctions here. So the two are pivotal response training or PRT, and the other is joint attention, symbolic play, engagement, and regulation or JASPER for short. Certainly JASPER is a lot easier to remember than all of that. So generally speaking, you see here where there's kind of a difference between the primary focus, the goals, the approaches, and what the target population is. One of the big things here is that the PRT is generally used from infancy throughout adulthood. PRT is kind of more of a comprehensive approach, and it's aimed in a broader aspect at certain kind of pivotal components, right? Core skills. And so that's usually things like motivation, self initiation, um, sometimes things like self management or regulation. So that's really the core focus, right? It's sort of like a more foundational, basic level. Jasper, by comparison, is primarily used for very young children and some older pre-linguistic individuals with ASD. So, kind of not necessarily learning those language skills yet or having issues with those language skills. It's a little bit more narrower in its focus and a little bit more specialized. It really focuses more on joint attention and types of play. And indeed, play skills kind of go hand in hand with joint attention. Right, so what joint attention means is I can be doing one thing, but then something else goes on, and I can notice that, and I can kind of bounce back and forth. This is a bad analogy because you wouldn't use this in NDBI because it is for younger kids. But yeah, I'm a bit of a gamer. I like Xbox. Sorry for those PlayStation fans out there. But if you're playing games online, you're playing video games. You are all about joint attention. You're doing one thing, you're hearing something else, you're paying attention to the background, seeing if somebody's trying to sneak up on you. I love Call of Duty, so somebody's always trying to sneak up on me. That's what I'm talking about with joint attention. Now, young kids aren't dealing with that. Hopefully, they're not playing Call of Duty. But they do have to do a bunch of different things, right? They're touching things, they're listening to the sounds that touching is making, the textures, they're doing all these different things. And especially for kids with autism spectrum disorder, that can be kind of difficult. And when we start talking about play and how it advances to where now you're interacting with other kids, that joint attention can play a particularly interesting role. So that's really what Jasper focuses on more so than the PRT. So the ABA and the NDBI are a little bit more involved as far as the interventions. The next few I'm going to talk about are a little less so. And in some ways, they kind of combine different aspects of those two treatment modalities. So the first one is Early Start Denver Model or ESDM. Now, you can think of ESDM maybe better as being sort of like a program rather than as being an actual treatment or therapy, right? So it's sort of like a curriculum that's actually developed, a program that's meant to be followed. What Early Start Denver model really looks at is a play-based kind of relationship focused type of therapy. So in that regard, it's a little bit more of like the NDBI kind of aspect, right? As being play based. It combines some aspects of ABA though, along with those developmental sciences. So it's almost a blending in a way of ABA with the NDBI, especially where we talk about the play-based component, right? So the idea here is that kids are kind of actively engaging in certain activities, and then the therapist or the parent in this case are kind of like there to be guides, mentors, and tie-in sort of lessons. And it's a key thing, right? So far, I've been talking about like therapists, but I mentioned parents. A big difference with ESDM is that parents are really actively involved in this model. That's really, really key. And in fact, even the next therapy or program I'm going to talk about is also shared with that, where parents really play a very active role. Um, and in fact, oftentimes the parents or the caregivers are kind of viewed as being the co-therapist. So you can probably tell by the name, Early Start Denver model, that we're starting pretty early. So it's best for ages 12 to 48 months, right? So basically 1 year of age to 4. The focus is on shared attention, imitation, playing. A really big component of ESDM is on modeling, so like showing the behaviors that you want the child to engage in. Um, because there's a huge need, and that's really ESDM, it really, really strongly focuses on this caregiver being very, very active. So oftentimes it can be kind of difficult if the caregiver just isn't able to do that. So especially things like, single parents or families where there are two parents present, but both of them have to work. This probably isn't going to work, because when I say a really significant like participation level from the caregiver, from the parents, I'm talking about upwards of about 15 to 20 hours per week. So that's one of the big criticisms of ESDM. It's actually been seen to be pretty effective, but it's really, really, really intense, especially when we talk about the time commitment that's needed. Now, it's worth noting, there's a reason behind this. And, I've often even told clients when I do therapy, going to therapy once a week, which is kind of the standard for an hour, is great. It gives you some ideas. But when you're talking about really making a change, you're talking about 1 hour a week at a therapist compared to 168 hours in that week. Granted, a big chunk of that is time spent sleeping, but it's kind of difficult to overcome that with just 1 hour, right? Especially if you're dealing with some really major challenges. And when we're talking about young kids with ASD, an hour a week just really isn't going to cut it when we're talking about all the things that a normal child is learning within that time frame. So that's the reason why this ESDM is so intensive. It has some really good outcomes, but because of that time commitment, it really does limit the amount of people that it can be applied to. So the next one I'm going to talk about is TEACH, which is short for Treatment and Education of Autistic and Related Communication Handicapped Children. Another of these therapies that's kind of a mouthful. So TEACH has been around for a while. It was first created by, I believe it was the University of North Carolina, or maybe Duke. So it's been around for a little bit of time. You can actually find a lot of resources online from TEACH. And whichever school created it, I always kind of tend to forget which one it is, if it's UNC or if it's Duke. Actually have a lot of free resources available, free classes that you can take online that talk about this. So what Teach is a program. So just like the ESDM, right? This isn't like an actual therapy so much as it's sort of a program. So it includes elements of different therapies, including a little bit of the behavioral component. But it's really sort of more of like a curriculum than it is like a specific therapeutic intervention. It also has a big component of education behind it. It's based on the understanding that individuals with autism are often strong visual learners and frequently benefit from a predictable, organized environment. So, what TEACH really looks at when we say education is really educating caregivers, the parents, or whoever the caregiver may be, to help them understand what the child needs and what's going to help them thrive. So a big focus here is that parental involvement, that caregiver involvement, but not necessarily to the same level as that ESDM. Psychoeducation is a big part of this. So that's the reason why Teach has a lot of different classes and stuff, free resources online, is it's meant to help parents better understand what autism is and what their kids need when they have autism. The big focus is on things like physical organization, visual supports, creating schedules and routines and following them. And when I say physical organization and visual supports, oftentimes that can even be things like having a chart or a calendar up in the kid's room, or checklists so the kid can go up and actually like mark down things that they need to do today or prepare for things that are going to happen later in the day. The parental involvement is not just understanding that the structure is what's needed, but also kind of changing their focus and their demands on the child to meet within that need for structure and organization. One thing that also is a big part of Teach is this work activity systems. So what that means is that you are clearly conveying to the child kind of the effects from engaging in tasks. So it's not just enough to say, clean up your room, right? It'd be, today is Monday, you clean your room on Monday at 5 p.m. It's on the schedule that's posted in your bedroom. The reason why you need to do this is because if you don't, your room gets really dirty, it gets really smelly, and when I walk in, I trip on your toys. It's very clear like that and structured as far as conveying, not just what the expectation is, but when it should be engaged in, and also, the reason behind it. And that's really important because oftentimes with neuronormative types of children, sometimes, but adults more so, you're more readily able to kind of pick up on the why behind things, whereas neurodivergent individuals, especially children, don't really pick up on that social aspect of the why they should do something. All right, so the last of the kind of programs, intervention, larger treatments when we talk about really behavioral interventions is something called EIBI. Which I feel like is, the EIEIO. So early intensive behavioral intervention. That's what EIBI stands for. So EIBI is a comprehensive evidence-based therapy for young children with autism spectrum disorder that is rooted in the principles of ABA. Its main goal is to maximize a child's potential by accelerating their rate of learning and development across various skills while reducing challenging behaviors. A good way to think of it is that the EIBI is sort of a more intensive version of the Early Start Denver model, of the ESDM. Usually it is enacted earlier, and usually it involves even more intensive time commitment. So if you remember with ESDM, I believe it was 15 to 20 hours. Usually EIBI, especially early on, it's 20 to 40 hours a week. And it's usually initiated before age 5. So early start happens early also. But generally it's more like at 5. So there's a little bit of a delay on it. One thing with EIBI is that it also really strongly kind of involves more of a therapist and caregiver, and usually other people working together. So that's really kind of a big distinction here. And indeed, a lot of the stuff with EIBI, it may use elements of ABA like the DTT, NET, but the therapist who's developing these plans, or whatever practitioner is developing them, usually creates a really highly personalized treatment plan. It's very, very structured. It includes a lot more components than Early Start Denver model would. So what I mean is that for this, the EIBI, It may include parental involvement, what they're going to do, what they're going to work on. It may include, what the teachers are going to be doing. If, say, the kid's going to pre-K or daycare or something like that, it'll integrate that. It'll integrate what counselors are doing. It's just really, really, really detailed, very personalized, and very comprehensive in what it looks at. And it usually does look at a variety of different skills, right? So it may look at communication skills, social skills, play skills, living skills, as well as just educational attainment, like learning colors or learning, the alphabet or something like that. So it's a lot more expansive in that regard too. One thing that's kind of interesting, so Head Start programs, some of them do use this EIBI or have tried to. But again, it's kind of like super complex, and it's also something that involves so much time commitment that my understanding is a lot of them haven't been that successful. And it's not because the EIBI isn't a good program, it just has some basic limitations. And when you think about Head Start, like most of the parents, the families who use Head Start are low socioeconomic status. Many of them are trying to work 3, 4 jobs just to make ends meet. So if you have a caregiver who's working that much and then asking them to commit to 20 to 40 hours, even if they're not doing all of that time, they're still taking the kid to daycares, to teachers, to therapists, that's a lot to ask of somebody. And especially if the decision is between doing that or putting food on the table, it can be kind of difficult. All right, so the next 2 slides are going to focus more on specific disciplines, specific fields. And especially what I'm talking about is, obviously with this slide, speech language pathologist or speech language therapy. And the next one, I'll talk about occupational therapy. So speech language therapy addresses challenges with language and communication. It can help people with autism improve their verbal, nonverbal, and social communication skills. The overall goal is to help the person communicate in ways that better meet their needs and their goals. Obviously, we're talking about speech language therapy. We're talking about it being delivered from a speech language pathologist. So some of the programs and therapies I just talked about are usually delivered through the ABA context of things like by the registered behavioral technicians, BCBAs, or therapists, social workers. This one is solely done by speech language pathologists. Now, there's a couple different components to language, and I've talked about this at different stages throughout the semester, but we have things like expressive language, like what I'm doing right now, right? I'm expressing my thoughts, my views, what I know, my knowledge with all of you. So it'd be expressive. It comes from the person themselves. Receptive language is your ability to understand what is being communicated from other people, right? So you're receiving that communication. There's another component here which I haven't talked about, which is called pragmatic language. So that is language communication that is being done for purpose. And you probably think, well, isn't that what all communication is being done for? Well, not really. I mean, really sit down and think to yourself, how much of what you say every day, if you happen to be somebody who's verbal, actually is meant for a purpose, that's meant for a reason, like asking for a favor, getting something from somebody, reflecting a need that you have. I would say the vast majority of the language that we have is just to pass the time, to, maybe bond socially. Like it's kind of more abstract reasoning behind a lot of the language that we engage in. So speech language pathology and therapy really focuses on all these different little elements of language. There's also a component, and this tends to be fairly common with individuals with autism, is something called alternative augmentative communication, AAC. So what AAC is the use of images or technology, and so non-spoken words for communication. So it can include things like sign language, right? It's non-spoken communication. But it can also include things like speech output devices. A good example of that is even in Word now, Microsoft Word, where you can type out something and then hit, read aloud, and it'll speak it out loud, right? That's what I'm talking about, speech output devices. And there's a variety of different apps and software that do that. There's also a bunch of different apps and different programs that do things like image sharing, picture exchange software. So sometimes, for younger kids, when they're trying to do more of that pragmatic language, like maybe they need a glass of water, so they can have a picture pop up on a phone that looks like a glass of water, and they can point to the image and show it to, their caregiver, and they can get a glass of water, and maybe that's how they communicate. So speech language therapy is really especially important. It can be used for all ages, and indeed there's speech language therapy for things that aren't even autism, right? So things like stuttering, language issues, whole host of different concerns. But specifically with ASD, it really is meant to be very early on utilized, right? There's kind of a window of opportunity. They call it critical period for children to really develop language skills. And if they grow out of that critical period, it's really difficult for them to learn those skills. And indeed, and at one point, it just becomes impossible. So early intervention is very key, particularly for kids that are struggling with language or that are nonverbal, right? So that's really key. There is a bit of a barrier here, so there aren't really a plethora of speech language pathologists throughout the country. And this is definitely one of those areas that, depends on the location. Rural areas, it's a lot harder to have access to these resources than in urban areas. Poorer states, a lot harder to find access than richer states. So there's a whole host of little issues there that could lead to a barrier. Also, it could just be really expensive. And oftentimes, you're going to these pathologists not just once a week for maybe a few weeks or months, but oftentimes it's over the course of many, many years, especially for children with autism that are particularly affected and nonverbal. All right, next up is occupational therapy or OT. So, OT is a personalized healthcare service that helps individuals develop the skills needed to participate in meaningful daily activities such as self care, learning, socializing, and play. Occupational therapists use a holistic approach to address core challenges related to ASD, with the primary goal of increasing independence and improving overall quality of life. As somebody who's worked within the healthcare setting, and especially in an integrative healthcare setting, so one where therapists work with primary care physicians and physical therapists and nurses and all sorts of things, I can say that there is probably no profession that is more misunderstood than occupational therapy. Every time I've suggested to a client that they need to talk to an occupational therapist, I mentioned this earlier, right? The first question they give me is, "So you're telling me I need to get a job?" Right? I'm like, "No, it's not what they do." In this context, that term occupations is used as a meaning of like everyday activities, right? So things that you want to do, things that you need to do, or things that you're expected to do sort of on a daily basis. So that can be things like taking a shower. So say you're somebody who has physical limitations. Maybe you're somebody who's really worried. Like I've been in a shower before and I slipped and fell, and now I'm really worried to take a shower. And that's really affecting me because I'm smelling. I know I have hygiene issues. So an occupational therapist may step in then and maybe find ways of allowing you to take a shower or bathe, take care of your hygiene needs in a way that won't make you afraid of falling. So maybe it's like putting skid plates down on the shower, or finding something like a bench for you to use when you're in the shower so you don't have to be standing, or finding ways for you to take maybe baths or something like that, right? So that's a really simplistic way of talking about this, but that's really what occupational therapy does. And it is used in a variety of contexts, not just with autism. Specific to autism, they do look at things like sensory integration, emotional regulation, and really just finding those ways of working around maybe hypersensitivities to sensory stimuli, or behavioral components, especially things like anxiety inducing events, to try to find a way for these kids or these adolescents or even adults to still engage in those meaningful kind of needed activities that they just do day to day. On a side note, oftentimes, I kind of feel bad for OTs. I've known more than a few OTs. They do an amazing job. But not only do people not really understand what they do, but sometimes there tends to be like overlap in what they do, kind of like bleeding into other professions. So sometimes some elements of what they do can kind of like put their toe a little bit over into what physical therapists do, or into what counselors do, or into what like nutritionists may do. So not only do people not really know what they do, but other health professions kind of tend to accuse them of trying to like overstep. So I always feel really bad for occupational therapists, but they do a really great job and serve a really important role in the treatment of many people, children, adolescents, and adults that have autism. All right, so the next few slides are going to be not necessarily specific therapies or interventions and not specific to certain disciplines, but kind of general aspects to interventions. So the first one is social skills training. So what I mean by general aspects is with social skills training, this is something that can be done in ABA. It's something that maybe an occupational therapist would work on. It's something that a speech language pathologist may work with their client on, and it's also something that a therapist may work with them on, right? So there's a lot of different people kind of involved in this. Social skills training, or SSTs, are structured evidence-based interventions designed to explicitly teach the unwritten rules and skills necessary for effective social interaction and communication. So social skills are really difficult for individuals with ASD. In fact, it's part of the diagnostic criteria. They're not really good at picking up on these social norms and kind of customs and schemas that many of us who are neuro normative would kind of take for granted and maybe even be difficult for us to distinguish, right? So there's a problem here, though, in that doing these types of therapies, oftentimes can be difficult because it forces the child, in this case, to be in social settings, which may be anxiety producing, which may be difficult because you don't know. Like if you have a kid and you're encouraging them to go up to, a classmate and just strike up a conversation, right? Maybe it's a classmate they never talked to before, and they do that. They do everything right, and then that kid turns around and says something really nasty to that kid, to the one you're working with, right? That could totally erase everything that you're just doing. So there's kind of some difficulties here. There's a bunch of different ways in which these social skills are taught, that these kids learn it, and that you can provide some kind of structured intervention. Probably the most common is just direct instructional method, just explaining to the child kind of like how social situations work, explaining to them some of these kind of unspoken rules. One area that I've seen work really well, especially with younger kids, is also role playing, right? So I mentioned in a real world setting, it's kind of difficult. You can't tell a kid, go up and talk to this kid, because what if that kid tells them off or is really nasty, right? And undoes the work. Well, through doing role playing, you can build those skills. And then once the kid feels better with it, maybe you can start introducing role playing for events like that. Well, what do you do if you go up to a kid and you're trying to be nice and talk to them and they're mean to you? How do you handle that? Well, you can put that up in role play. Social stories and scripts. So these are actually kind of fun. Back in the day, there were more like cartoons, like actually drawn cartoons that would have like little social stories and were sort of like conversation starters where you could talk to the kids and talk about like what they see in these little cartoons and stuff like that. A more modern version, I've seen versions of this that use things like anime. I've seen it where kids are able to develop their own like anime characters and work through some of their social anxieties or fears or concerns or even past events that have come up, because sometimes it's difficult for them to talk about like this is what happened to me, but if they're talking about their anime character, they could talk about what happened to that anime character even though it was really what happened to the kid, and it'd be a little bit easier for them to talk about that. There's also things like computer games, apps, and stuff like that bring up these social stories, and can even be fun little like interactive things for kids to learn those social skills. Peer mediated instruction or groups. Oftentimes, when I've seen this, which isn't common, is where it's a group of kids who also have autism spectrum disorder, and it's them actually practicing with one another in kind of a controlled setting, social skills. Um, Not too common. I don't really know why, because I think it does work and I think it could be really helpful. It can also be helpful just in helping those kids like find other kids who they can relate to. Generally speaking, social skills training is best for school age children and adolescents, um, because they're the ones who are actually actively kind of involved in this. When you have kids who aren't really in school yet, or maybe even daycare, this is just kind of too advanced of a skill. You kind of want to focus on other more basic skills. Some of the barriers, there's really limited real world generalization. So there's that wording, generalization, right? If I'm doing role playing, I don't necessarily know, and I can't say all the things that this kid is going to be exposed to in talking with other people. I mean, heck, I'm a counselor, I have a background in psychology, and I can tell you from one day to the next, I'm kind of surprised by half the stuff people tell me in public, right? I'm half surprised by half the stuff that I see just when I'm out with my family, going to the grocery store. So that's something that it's kind of difficult to role play and create what if scenarios or anime sketches for everything that the world can throw at you, right? We try to make it as generalizable as possible, but it just inherently can be a little bit difficult. All right, up next is family-based interventions. So, family-based interventions are a comprehensive approach to support the entire family unit by enhancing communication, strengthening relationships, and providing family members with effective coping strategies. These interventions are built on the philosophy of family-centered care, recognizing that a child's development is heavily influenced by the home environment. This is really important because there have been studies that have shown that parents with kids that have autism spectrum disorder are at a higher risk of divorce, higher risk of stress and stress induced slash related problems like anxiety, health problems, heart attack, stroke, things like that. There's a higher incidence of domestic violence within families who have children who have autism. So there's a whole host of different issues that can come up. And really, the family-based interventions approach looks at the fact that oftentimes, a disruption in a family unit or something that's unexpected or that puts a little bit of stress on it, the earlier you can find that and provide effective coping mechanisms or just even an outlet for the family as a whole to be supportive as possible to one another is really the best outcome. And there's a variety of different programs. One of the ones that comes to my mind the most is listed on here. It's called Triple P. It stands for Positive Parenting Program. Um, Really, the key component to Triple P, and there's like, I don't know, a dozen different specific types of Triple P programs. There's ones for toddlers, there's one for children, there's ones for children that also have co-occurring mental health problems, for adolescents, you name it. But the key component is understanding its education on what autism is, and it's fostering productive, supportive roles and communication styles, right? That's kind of the overarching theme of any of the triple Ps. And indeed, that psychoeducation can be really important. I've seen it in families where, caregivers, parents get really, really frustrated at the kid for something that's kind of typical for a neurodivergent child or a child with autism spectrum disorder, something like, food aversions or sticking to routines, or a really, famous one is, a lot of kids, I mentioned this when we talked about some of the challenges, a lot of kids with autism in adolescence have really severe sleep disruptions. So I know some parents are like, my kid keeps waking up at like 2 o'clock. They come out and I tell them, go to bed. You need to go to bed. And they get really frustrated at it. Well, doing that isn't really a productive, healthy way to communicate with the child. So then the child's going to start probably developing behavioral issues because they're hearing their parent kind of criticize them for something they may not have much control over. I'm not saying we should accept, disruptions to sleep, but there's just different ways of supporting it. And that's really what these family-based interventions really look at. Outside of that, it also talks about, things like self-care, stress management, that it's okay. And oftentimes when you have a child who's special needs, the parents, if there's parents or there's two present, they kind of give up on their personal needs to help that child. If they're in a relationship, oftentimes the relationship suffers. Oftentimes, other siblings of the child, the relationship with the parents suffer as a result of it. So it's really taking the time to make sure that all of the family is being taken care of and being given that emotional support that's needed. So really critical. In my experience, most of the family-based interventions, that component of ASD treatment is usually handled by mental health therapists, counselors, so LCSWs, LMHCs, psychologists, and also case managers and social workers. So there's not really much to this slide, even though it's actually a really interesting topic. So tech-assisted interventions. Over the last few years, there has just been a massive explosion of apps, software, technologies that are designed to help with a variety of different therapies. There's a bunch of different tech out there for helping speech development, speech language therapy. There's apps now to help with ABA. There's apps to help with social skills training. What's interesting, and that's why I said this is actually a really interesting topic, even though there's not much on the slide, is really the hope of what the future could hold, right? When you start thinking about things like artificial intelligence and what role artificial intelligence may have in helping things like social skills development, it could be really a very exciting time. There's some potential pitfalls here and just some things to kind of consider. One of them is that some kids who are lower socioeconomic status may not have access to this because these are usually going to be paid. People take it for granted, but there's many people in the United States that can't afford even Wi-Fi, internet, or the devices that you would use for these types of tech. Also, another kind of troubling component is that children with autism already, in my experience and in studies, already struggle with overusing screen time, right? Overusing their cell phones, computers, video games. So, are we kind of unintentionally encouraging a behavior they shouldn't be engaging in, or that we're trying to maybe limit a little bit by then putting their therapies and treatments on those things we're trying to limit their access to? But I think, many of you have probably already looked into this topic, and I encourage you to continue to do so because there really are some really interesting um, ideas coming out of using technology to help with therapy and treatment in autism, and indeed a lot of mental health disorders as a whole. All right, the last component here of really ASD treatment with children is psychotherapy. So psychotherapy is counseling, right? It's usually one-on-one counseling where an LMHC, LCSW, psychologist, rarely, but sometimes psychiatrists, sit down and really talk to a client, talk to the child. Or sometimes it can be family therapy and things like that. When it comes to psychotherapy, there really isn't a specifically created psychotherapy designed to help those with autism. Really, what happens is that we kind of take different therapies that are just established and evidence-based within psychology and then kind of tweak them, modify them to address really specific components of ASD. And usually that's things like rumination or problematic behaviors. So, in my experience, probably the two most widely used therapies that are applied to aspects of autism is cognitive behavioral therapy and dialectical behavioral therapy. So, CBT is kind of widely considered to be kind of one of the most evidence-based practices within psychology. Now, that's not really fully accurate. One of the reasons why is CBT is just a very structured approach. So it's very easy to do experiments and to do research on it because it's so structured. Um, that being said, though, there is a lot of research of it being effective in a wide variety of different mental health conditions. And indeed, it is frequently used with people who have autism. So with CBT, it's an approach that helps individuals identify the connections between their thoughts, their feelings, and their behaviors. A therapist works with the person to change negative thought patterns to more effectively manage emotions, stress, and challenging situations. It's the most effective for individuals with higher cognitive and verbal abilities. And indeed, in my experience, especially adults with autism love CBT because it is kind of rigid, it is kind of structured, it's very cut and dry, and it's very clear. Right, so those are things that they generally tend to appreciate. So an example of CBT, right? If I have a kid who maybe I'm talking to them because they have temper tantrums, they get upset because something happens. I don't know, say their mom takes their cell phone or something like that, right? So what you would look at is the effect, right? So you're throwing a temper tantrum because your mom took the cell phone. So what is the reasoning behind this? Like what were you thinking? What was going through your mind? Like what was the precipitating thing, right? So you usually kind of look at going back and saying, okay, well, it's not just taking the cell phone because you want the cell phone. Maybe you wanted that cell phone because that helps you kind of, feel at peace, or it helps you calm down, or it's something that you just find interesting and that you want. It's pleasurable. And when your mom takes it, it makes you think that you're being punished, even though your mom isn't taking it for a punishment, but because she wants to talk to you and you're so distracted that you're on your phone. Right. So it's kind of looking at changing the way you think about a situation and adjusting the behavior pattern so you have a different outcome. It can be adapted into tons of different situations, tons of different mental health conditions. So that's one of the reasons why it's really used so frequently. Now, cognitive behavioral therapy really focuses on sort of like logic, how you think, and trying to change those thought patterns. One of the biggest criticisms of it, though, is that, oftentimes as a therapist, I can say this is certainly true. We can feel something that logically we know we shouldn't feel. You know, that may sound kind of weird, but oftentimes people feel all sorts of different things. A good example of this is maybe when we talk about romance. Plenty of people could be with somebody that on paper is perfect for them, right? Maybe they, are nice, they're supportive, they're attractive, all these things, but like I just don't love the person. Feelings aren't facts. That's a common statement within psychology. And it works both ways, right? Just because we logically know something to be true doesn't mean we necessarily have an emotional connection that matches that. So I'm saying all this because the second big therapy that's used quite a bit with those with ASD is something called dialectical behavioral therapy. It's similar to CBT. In fact, many people kind of consider it to be like a daughter of CBT or related to CBT. The difference, though, is that with CBT, it looks at cognitions, it looks at thoughts, perspectives, and trying to change them. With DBT, we don't focus so much on thought patterns as much as on emotional regulation. Because with DBT, we understand that sometimes, emotions aren't really connected to thoughts. Sometimes we feel things, sometimes very, very strongly, that's difficult for us to control, especially kids who have things like really strong emotional meltdowns, neuro crashes, temper tantrums, things like that. So oftentimes DBT can be used quite a bit there. And in fact, I would even say, in my experience, DBT is kind of used much more often now than CBT. It just kind of depends on the situation and the behavior that you're trying to address. All right, so far in this lecture, I've talked about really childhood, and I've talked about therapies and treatments addressing autism in childhood. Um, in some ways, this is where the discussion ends as far as actual therapies. In the next few slides, I'm not necessarily presenting, specific therapies or treatments in the detail that I just presented it. I'm really talking about more things for you to consider, things to keep in your mind, because really, historically, when it comes to treating autism, the focus has always been on children, less so on adolescents, and almost nothing at all on adults. That is beginning to change. So in the next few slides, I'm just going to present, kind of some of the things that we're trying to look at and that we're trying to address rather than on specific types of therapies. So we'll start with adolescence. And indeed, with adolescence, I said most of the focus has been on children. Well, adolescence is still kind of grouped into that. There's not as much interventions, and usually children who were identified early as having autism spectrum disorder, by the time they get into adolescence, they really probably don't need as much interventions, especially if they're higher functioning. But there are still some treatments available. There are programs available. So there is still a little bit of structure. Where the difference is, though, is that as we go into adolescence, there's a whole new context to different things that come up, right? We start experiencing those social pressures a heck of a lot more. I mean, just think back to when you were in high school, right? There was a big difference between middle school and high school. You definitely felt those social pressures. You started to see where people broke off into like cliques, different little subgroups. And because of that, you start to become more aware if you're not fitting in, if you're not part of the popular group. And sadly, if you're neurodivergent, oftentimes you're really aware that you're not fitting in. This is especially true if you have other aspects of group membership that similarly kind of have that shared component of not fitting in or feeling ostracized or stereotyped. And when you have both, it can be particularly problematic. So, for example, one of the most well-studied groups are those that are LGBTQ plus and have autism. And in fact, they found that group sadly has really high incidence of being bullied, really high incidence of sadly suicidal thoughts, suicidal acts, and lower incidence of things like self-esteem, self-confidence, and things like that. And in fact, that's been a group that's been really focused on in research quite a bit. So no therapy is really in place here, right? We still use the therapies I just talked about, especially when we talk about psychotherapy, CBT, DBT. But really the focus needs to change a little bit, right? So it needs to start looking at self-advocacy, of teaching these teens of ways to build their own self-confidence, their own self-esteem, to advocate for themselves, and also to work within social settings, so that peer mentoring. Oftentimes, some of these interventions are best when we're talking about teens with things like anxiety or transition challenges, but there is definitely some limited areas here. One of the biggest ones is that there's just not a lot of therapists, and again, really no specialized treatments for this age group. And indeed, there's kind of still quite a bit of stigma. The other problem is that most of the programs in place, most of the treatments in place, eventually you kind of age out of it, and we call it the cliff. So really, it's designed for children, kind of a little bit adolescents. But once you turn 18, give or take a few years, you're kind of just left to your own devices, right? Even though there's less programs and therapies for adolescents than there is for children, there's virtually none for adults. And historically, research has been very sparse in looking at anything beyond adolescence. So the other part here too is that even though there may be some programs and things in place, once a teen becomes a teen, they may look at some of these as being kind of childish. And indeed, if you've ever been to like a therapist's office who specializes in autism for children, there's toys for kids. It's really designed to be more for like early childhood, maybe even toddlers, than it is for teens. A good analogy to this is sort of like pediatricians' offices, right? Like no 16-year-old is going to want to go to a pediatrician when there's, SpongeBob SquarePants stuff all over the place and stuff like that. I mean, you technically can. I think pediatricians can see till you're like 21, but a lot of teens would want to start seeing like a family care doctor then. And we have the same issue with therapy and other aspects when it comes to autism. So as I mentioned, there's really kind of this concept that we have in autism, that there's sort of this adult cliff, right? So childhood, there's a ton of resources, ton of specific interventions, therapies, treatments. Adolescence, it kind of trails off a little bit, but there's still some there. And then you hit adulthood and you just fall off the cliff, right? It's expected at that point you have all the skills you need. Now, this is notwithstanding the idea that maybe somebody wasn't diagnosed in childhood or adolescence. And there certainly are plenty of adults who get diagnosed as adults for the first time. But there's also a change as far as what kind of components exist, what autism looks like and how it's different in adulthood, especially early adulthood, than in adolescence or in childhood. So this can be kind of an especially difficult time for those with autism. Typically the sense of independence experienced in this stage also has some significance, depending on the extent and degree of autism symptoms, right? So if you're somebody who's really low functioning, and this is a life stage where you're expected to be a lot more independent, that can be difficult to process. Maybe you are still somebody who's like moving out from your parents' house, trying to be more independent, but now all of a sudden that structure, that organization, those support systems that you had in place aren't there anymore. And while we all go through this, for somebody with autism, it can be particularly difficult. And then you add to this the changing conditions of now you're dealing with college or university and the stresses there. You're dealing with work in that type of a social setting. And oh my God, probably the worst of the worst, right? We're also maybe interested in dating, starting some romantic, relationships. And those can be really problematic. And that's one area in particular that, really there's not a lot out there to help adults with autism do things like date. It's changing now. There are some therapists that kind of specialize in this, and there's other types of specialists that really focus on it, but it really isn't very common. So really some of the things to focus on for adults that have autism as far as future research and future initiatives is to look at advancing the independence, looking at aspects of employment and mental health, and helping with things like social cohesion, finding work and maintaining relationships at work, and romantic uh, engagement, however that may look. So we talked about early adulthood, and how that is challenging. Well, I can tell you one area that there is not even really that much research being done in is aging adults that have autism spectrum disorder. And indeed, for a lot of reasons, when you look at the elderly population today, people who are 70s, 80s plus, they grew up in a time when really autism wasn't even understood. It certainly existed, but it wasn't well understood. It wasn't very much diagnosed. I think the stats in the 1940s, 50s, 60s was that it was probably 1 in 1,000 to 1 in 10,000 people that had ASD. Compared to now where it's 1 in 70, and that number is even high by some estimates. So aging adults are perhaps some of the least studied individuals with autism. Those in middle and late adulthood grew up in a society with very limited supports for ASD and often either don't know they have ASD or were diagnosed much later in life as adults. It is a growing concern and area of research as the ASD bubble starts to age. So, what I mean by that is the statistic I just mentioned, right? Back in the 40s, 50s, 60s, it was believed 1 in 1,000, maybe even up to 1 in 10,000 had autism spectrum disorder, compared to now where it's 1 in 70. So what you have is a lot of adults now that have autism and know they have autism, but even more teens and even more young children. As they age and as they go through that system, you're going to start seeing way more people going into middle adulthood, going into later adulthood that have lived with autism their whole life, right? So that's going to be a drastic change, and they're aware of it and they know about it. But how does autism look as you start dealing with things like midlife crisis, empty nest syndrome, the changing medical conditions that a person's going through? And also, and this is an area that definitely needs to be researched, How does things like neurodevelopmental disorders like autism spectrum disorder and attention deficit hyperactivity disorder look when you're dealing with things like dementia? So these are a lot of different components that really need to be looked into. Another component is remember a lot of the kind of co-occurring comorbid medical conditions that are present with a lot of people with autism spectrum disorder. Are there increased incidence of things like cardiovascular disease and other things as we go into middle adulthood and later adulthood? One interesting kind of side note here then is uh, since we're talking about late adulthood, what about things like nursing homes? There's very little support right now, or even an understanding of the need for elderly support for those that have autism spectrum disorder. And nursing homes kind of present some unique challenges. If you've ever been in an assisted living facility, there's some aspects of it that would probably be beneficial for those with autism, like a high degree of structure and organization. But then there's probably other things that wouldn't, like sensory problems. Um, some aspects of change to the daily routine that the person may have experienced prior to coming to the ALF. So those are some areas that are kind of interesting. I have seen some stuff where they've actually started looking at maybe even the prospect of like assisted living facilities, nursing homes that either are specially designed for those with autism or have like a neurodivergent wing. Um, Kind of an interesting thing. Not a lot of research, or like I said, even understanding of a need for this. But it's certainly something that's kind of interesting to think of. And then also just how those conditions change. Like, how do we still respect the dignity and the autonomy that a person should feel and have as they age? Aging with dignity is certainly a new uh, growing concept that we should age with dignity, with autonomy, and age well. So it's kind of interesting to think about how that would look for autism spectrum disorder. So the final component here is a little bit of a soapbox moment. So my apologies, y'all. But I talked about the existing therapies and treatments, and I talked about kind of the future and what autism looks like across the developmental lifespan and some of the gaps there. Well, the reason why I'm keen on talking about this is there's many of you who are listening to this video, many of you who are in my class who will be that future, who will have that opportunity to look at things like nursing homes for autism spectrum disorder, what adulthood interventions may look like for things like dating, marriage, finding work. You could be the face of that future, of that research, of those therapies, of those interventions. And it's worth noting, just some of these gaps that do exist, because who knows, maybe you'll be the people that discover a way to overcome these gaps, to overcome these challenges, to break down these barriers. And probably one of the biggest ones is that there is access inequality. Some regions of the country, some racial groups, some ethnic groups, lower socioeconomic status people, and those who are uninsured simply do not have the same access as other groups do to these practitioners, to these resources. In many areas, there's a lack of trained providers. So things like speech language pathologists just across the country are kind of, there's not enough of them for the need. But even things like psychologists and therapists, where there isn't as much of a shortage, there's not that many of them who specialize in autism, especially specific components of autism. Additionally, things like family stress and cultural sensitivity gaps. Oftentimes it's easy to look at things like disparities of diagnosis and treatment in different racial and ethnic groups and look at it as being a systemic problem with the healthcare industry. But sometimes the reason for those disparities also do come from within those groups because of things like stigmatization of autism spectrum disorder. Ethical focus on neurodiversity and autonomy. This is something I always like to kind of bring back to home, but how much of treatments and therapies are there to help a child do their best and to overcome adversity, Or are we engaging in some of these therapies and treatments to try to basically make the kid fit in, right? I mean, we have a right to just be different, to be divergent. We shouldn't have to force a normative standard on somebody who really doesn't want it. And that's really, where the neurodivergent community would come in and talk about advocacy, right? Should we really do an intervention if the behavior in question isn't really problematic? It's just different from what the normative standard is. So, sort of an ethical issue there. Of course, one of the biggest barriers, challenges, is that there's just not a lot of ASD specific interventions. A lot of the interventions we use, especially in psychotherapy, but even in other areas, are really broad. They're interventions that were meant for the general population that we kind of tailor, tweak, adjust to fit the needs of individuals with autism. That's something that probably needs to change moving forward. And of course, also the focus on childhood definitely needs to change because autism is a lifelong disorder. Kids who have autism become teens who have autism, who become children, adults who have autism, and become elderly individuals who have autism and may need to be in nursing homes that need to be sensitive to their needs. So we definitely need to develop more of a lifespan approach to autism spectrum disorder. So this lecture has been pretty long. My apologies on that. I wanted to end with that note because, as I said, you all are the future of autism research, of autism treatments and therapies. So hopefully you found this interesting. And of course, if you have any questions, comments, concerns, please feel free to reach out.